This lecture is about the treatment of bipolar disorders. By the end of this lecture, you should be able to understand the various treatment options for bipolar disorders, and you should be able to explain what a treatment algorithm is good for. In terms of treating bipolar disorders non-pharmacologically, cognitive behavioral therapy might be of some benefit during depressive phases of bipolar disorders, and potentially even during manic phases of bipolar disorder type 1, but it can't prevent cycling. There are psychosocial interventions that are non-pharmacological in nature, obviously, and there's quite a few of these. So, for example, one might try to improve the ability to identify and intervene early with warning signs of recurrences of mood episodes. One will try to increase one's acceptance of one's illness. One would try to enhance adherence with drug regimens. One would try to enhance ability to cope with environmental stressors associated with the symptoms. One would try to stabilize their sleep and wake rhythms and other daily routines. One would try to re-engage with social, familial, and occupational roles. One would try to enhance family relationships and communication, and one would also try to reduce drug or alcohol misuse. Some other general coping strategies for dealing with bipolar disorders include reality checking, that is with someone you trust. The so-called 48-hour rule, which basically states that if you were, let's say you happen to be in a hypomanic or manic episode and you're making some major life decisions, such as changing your job or leaving your loved one or moving to a different country, that you wait 48 hours before you make a definitive decision. An individual with bipolar disorder would also want to avoid certain types of thinking, such as all or none thinking, catastrophizing or fortune telling, mind reading others, and overgeneralizing. In terms of pharmacological treatments, it is possible to treat the individual phases of bipolar disorder. So, for example, one could be given antidepressants for the depressive phases of the disorder, or one could be given antipsychotics and other medications for the mania or hypomania phases of the disorder. There are also drug treatments aimed at stabilizing mood, and those are the focus of most treatments for bipolar disorder are mood stabilizers. There are three sorts of mood stabilizers. There's lithium, there's various sorts of anticonvulsants, and there's various sorts of atypical antipsychotic medications. In 1949, John Cade, an Australian physician, reported that a group of 10 manic patients displayed marked improvement following the administration of the metallic ion lithium. His report received little attention initially, but it was later shown that lithium is a mood stabilizer, usually defined as a drug that has anti-manic and/or antidepressant effects and also prevents cycling between depression and mania. Certain anticonvulsant drugs are also considered to be effective mood stabilizers, but generally not as effective as lithium. Two examples include valproate semisodium, marketed under the names Epival or Depakote, and lamotrigine, marketed under the name of Lamictal. And also, certain atypical antipsychotic medications are considered to be effective mood stabilizers. Three examples of these include quetiapine, marketed under the name Seroquel, the combination of olanzapine with an SSRI, a selective serotonin reuptake inhibitor. An example of this is a drug marketed under the name of Symbyax, and aripiprazole, which is marketed under the name Abilify. This diagram shows you a treatment algorithm, and treatment algorithms are increasingly popular in the psychiatric community because it's so difficult for a particular individual to know the current state of the literature related to any particular drug treatment. And therefore, certain individuals, certain researchers have taken it upon themselves to summarize which drug therapies have the best evidence in terms of their efficacy and also the best side effect profiles, and then they create so-called treatment algorithms. And that's what this diagram is showing you, is basically given a particular individual who has bipolar disorder, you would decide to put them on one of the first-line agents. So, for example, lamotrigine, lithium, or quetiapine, or any of the other ones that are listed here. And if that first-line treatment isn't effective, then you might add another drug, again, based on evidence that is summarized by the authors of the treatment algorithm in question.